Hey there, welcome to Cumberland Conversations. This is the place where we talk about the issues that matter most to you, your patients, and your community. We're diving into real conversations with real people, sharing insights you can actually use. Let's get the conversation started. Hey everybody, Rob Lillard, Medical Director of the Cumberland Pediatric Foundation, and welcome back to another episode of Cumberland Conversations, where we continue to spotlight some of our primary care and specialists here in Middle Tennessee and beyond. And today, I am happy to be joined by the team, and I always mispronounce this, the Pediatric Arthrogryposis Clinic at VUMC. And I'm joined today by Lydia Humphries, who is the Program Manager, and Dr. Robert Rinaldi, who is, I guess, Chair of...
Program Director for
the residency program, and then leader of this clinic, I guess. Is that correct? Yeah. All right, wonderful. So I want to learn a little bit about you both. I hear that Kentucky accent. So Lydia, we start to you. Tell me your background and how you got involved in this at Vanderbilt.
Yeah, I am from Cadiz, Kentucky, so a small town in Western Kentucky. My background is in healthcare administration. I went to Murray State University for undergrad and then University of Kentucky for my master's in healthcare administration, and then was there for a couple of years and came down to Monroe Carroll. So I am here as a program manager for multidisciplinary clinics, and arthrogryposis being one of them.
Wonderful. All right. And I never thought I would do this. I'm sitting next to a unicorn, a literal unicorn, because y'all are hard to come by. And this is, your background. I think, as I mentioned to you, you had a little difficulty finding an exit ramp off I-35. So you went to undergrad at Iowa State, got on 35 South, medical school at Oklahoma, went back north to Kansas City, got lost there for a while.
Yep.
Did a pediatric residency.
Correct.
Couldn't find your way out of Kansas City, so stayed around and did PM&R.
That's right.
For 3 more years. And that's not the typical way you would get there. But tell me a little bit about what drew you into that and how you got there.
Yeah, so I went into general pediatrics thinking I was going to be a pediatric neurologist, and rotated in a rehab rotation my second year of my Gen Peds residency. And it just really resonated. The whole idea behind rehab is increasing function in patients. We know we can't necessarily fix the underlying neurologic condition, but what we focus on is improving function and quality of life. And that really resonated with me. And it was my second year in that residency that I decided to go ahead and pursue pediatric rehab medicine. And that entailed a second residency in general rehab. Which is really interesting because I literally went from one day finishing up my general pediatric residency, the next day flipping over to inpatient adult units at KU Medical.
It's a tough switch, right?
It was a big switch.
Was there a particular, I always ask, is there a particular patient or experience where that, you mentioned there was something that flipped, but was there an experience or patient that you recall and said, this is why I want to do this?
Not really. I just think it was the whole gestalt of the month that I spent on rehab. And it just really struck me as this is what medicine meant to me. Is taking care of people and making sure people went on to live full lives the best they could.
Okay, wonderful. And so once you finished all that training, how did you find your way to Nashville? Where else have you been?
So I practiced in Kansas City at Children's Mercy for probably close to 20 years.
Okay.
Had an opportunity to go to Dallas and start the Division of Pediatric Rehab Medicine at UT Southwestern. So I took that opportunity, spent about 8 years there. Had an opportunity to come to Nashville, sort of the closing chapter of my career, I guess. My son was in college here at the time.
Okay.
And and we just decided to go ahead and relocate here, and just it was a nice opportunity. I got to come back to do medical education, which is my first love. So it gave me the opportunity to do that by running a residency program at Vanderbilt. And here I am.
So you've done a lot, obviously, with these, because again, kind of that unicorn theme, there's not a lot of you. How many practicing, maybe inside of pediatric PM&R, how many are there?
Yeah, so there are about 380 to 390 pediatric rehabilitation medicine physicians, board-certified physicians.
Okay.
Yep, so pretty rare.
Awesome. Well, great work. And so let's talk for a second about this particular clinic, which is very new. We're still kind of ramping up, as I understand. And when we talk about arthrogryposis, still struggle with that. We're not talking about a particular condition. We're talking about more of a presentation that can be from many underlying conditions. Is that fair to say?
Yeah.
Yeah. Okay. So, tell me a little bit about what you treat, what you see, and good candidates for the clinic.
Yeah, so arthrogryposis itself, as you mentioned, is really just sort of this catch-all phrase. that has multiple diagnoses under it. Basically, to get the diagnosis or be classified as arthrogryposis, we really only require a child being born with two or more congenital contractures.
Okay.
That's it. That fits the definition of arthrogryposis. Now, within that, you got a whole different subset of conditions that can cause that, whether it's underlying genetic conditions, underlying neurologic conditions. There are standalone conditions that have really no underlying genetic mutations associated, and they're just sporadic. So there's a whole subset of different conditions that fit under that sort of umbrella of arthrogryposis. Again, it can be as little as 2 joints. It can be as many as 5, 6, 7, 8 joints, major joints, small joints. As long as we've got those, those 2 separate areas that have contractures, congenitally based contractures, that fits.
Okay. Do you find that most of your referrals then come from primary care doctors, or maybe ortho they've been referred to orthopedics for, say, a club foot or something like that? They find something else. What's the flow that you typically?
Is it a little bit of both, would you say?
Yeah, I would say both. I think as we kind of things like this and more exposure, hoping that we get some straight from primary care physicians, because we do have orthopedic surgeons in our clinic. And so that's kind of the purpose of our clinic, is to have one longer appointment seeing all these specialists that they would need to see at one time. And so we're kind of getting a little bit of both, some from the NICU as well. So I would say most separate referrals, I guess.
Okay. And where's the nearest center outside of Nashville? Where would your catchment area be? Are you into Kentucky and Alabama and those areas? Or?
Yeah, I think Cincinnati Children's has one. Emory has one. I don't know if Lexington does.
Okay. Pretty loud area that you can draw from.
Yeah, our catchment area would be fairly large.
Okay.
Yeah.
What are the most common kind of, again, thinking I'm a primary care pediatrician, but what are the most common presentations? Of course, I always think of clubfoot, but what do you see as the most common joints that tend to be affected?
Yeah, so the most common presentation we know is a condition called amyoplasia. We don't really know the underlying cause of it, but these kids present with upper extremities, bilateral upper extremity internal rotation contractures, elbow extension contractures, and then wrist flexion contractures.
Okay.
It probably accounts for maybe 30% of all arthrogryposis diagnoses.
That doesn't sound like a subtle presentation.
No, it's not subtle at all.
Yeah.
It's pretty pronounced when you see it. It's one of those diagnosed. It's one of those conditions when it walks in the door, it's like, okay, it's amyoplasia. Yeah. It just really has a very sketch presentation. But that's probably the most common. And then again, we see kids who come in with symmetric contractures of the elbows, different joints. Just really depends.
But again, 2 or more think that they would do good fit for this clinic. Okay. You mentioned multi-specialty, multidisciplinary. So obviously we've got Dr. Rinaldi, orthopedics you mentioned. Who else is involved in this?
Yeah, we have 2 orthopedic surgeons, one that specializes in upper extremities and one that specializes in spine and lower extremities. We have a plastic surgeon in clinic. We have occupational therapy, physical therapy, of course, Dr. Rinaldi. We're kind of looking to expand to see if we can get a genetic counselor in clinic as well, just to have that full grasp of everyone on the team. These clinic visits aren't short, and that's for a reason.
Yeah.
And families know that, and they often tell us how grateful they are to just come to Nashville and beat the traffic for one day and sit in multiple appointments. And so they're typically about 2 hours, but
can you beat the traffic in Nashville? Is that possible? Because we need to talk if that's the case. Okay, all right. Okay, good.
Yeah, so they're usually there for about 2 hours, but they will see everyone on the team. And if there's any physical therapy, occupational therapy, splinting, or anything like that, they can get that same day as well. So parents are really appreciative of having, the clinic and being there for one clinic visit.
Yeah. So tell me a little bit about, when they come in and they have all that done, what's the typical follow-up? I mean, how much of this do they continue coming back to Nashville, or is it something you coordinate with pediatricians or family practice providers in more rural areas of, say, East, West Tennessee, Kentucky, places like that?
I think the preference is to have them come back to clinic. Yeah. Okay. For that, again, that multidisciplinary assessment or interdisciplinary assessment. That's the preference. And again, that is the advantage for the folks living in rural Tennessee or rural Kentucky, is they get that one-stop shopping. It's one visit, as Lydia said. They can avoid the traffic. It just makes life a little bit easier for them. The other advantage to the interdisciplinary approach is that team decision-making. These are incredibly complex kids. where you may be determining or talking about surgical interventions. You may be talking about occupational therapy interventions. We may be talking about genetic diagnostic workups, and all that decision-making can be made in the same clinic with the families present. So it's really advantageous for them to be part of the program.
And is there then a kind of plan of care and that's communicated to the primary care doctor, or is OT or PT and things like that done in the community? Is that kind of relayed about what they'll need?
Yeah, especially our occupational therapists and physical therapists are really good about being in contact with their local therapists back in their communities. And they'll usually come back, especially in their first year of life or their first year that they've seen us in clinic, every 3 months is kind of our cadence. And then after that, about every 6 months to see us back in clinic. And then for splinting needs or anything like that, if the local therapy isn't comfortable with that, we can always bring it back to clinic for those needs as well.
Yeah, great. So what is probably one of the most rewarding cases that you've had so far? And maybe you have more experience, maybe you relay something further back, but what are the biggest rewards that come out of this? What have you seen?
I think for me, it's making, and I can't think of a specific case, Rob, but I think it's what I found over the years of working with these kids is it just seeing them light up when they figure out a way to do something, making things a little bit easier for them, whether they become independent in dressing, whether we can get them independent mobility through power wheelchair systems. It's just those things we kind of take for granted, right? Because we're able-bodied. But when you take a child with a disability and they become independent in something, it's just really rewarding. So to me, it's just the entire process of finding those things that make life a little bit easier for kids. It's really rewarding.
Well, that's a good point, because you're actually doing a lot of like orthotic devices and assistive devices and things like that, help these families too, and all that. I mean, do they basically come in and leave with one, or?
Now, they don't get the equipment in the clinic, but we do make recommendations. And then they can go to the orthotist, or they can go to the durable medical equipment clinic. And then that's where we prescribe those things.
Well, that's fascinating. That's great. So tell me a little bit about getting a referral done, because I think that for a lot of us, we're like, that's a great clinic. Who do I call? What do I do? Do you have any information on that, Lydia?
They can refer to us through the Vanderbilt Health Connect system. It is a external platform for non-BMC providers that they can send us a referral through that way. Okay.
And that's for a lot of you out there listening, if you're not familiar with Health Connect, I mean, certainly it's something that the Vanderbilt system can set you up with. I think the easiest way, if you need information, email us at cpfnashville@gmail.com, and we'll be happy to give you the information to get started with that. But you even go old school, right? You've got a fax.
We have a fax.
Go for it. It's you all 1980s. I love it. Go ahead.
You can fax us the referral to 615-595-9275. That will come directly to me, and I can set up the appointments for patients and families.
Perfect. All right. Give me an idea of how long a patient might have to wait to get in. Right now, I know we're still in the early phases of this. Volume, I imagine it's a little easier.
It's not a terribly long wait. We can usually get them in within the next month or two into the clinic. So.
Perfect. All right. Wonderful. Well, this sounds like an amazing service. And it's something obviously that we don't come across commonly, but it can be very overwhelming as a pediatrician when you come across that thinking, what's my next step? So I think this is helpful for a lot of people to know they have that resource out there, and I appreciate y'all providing it. Any parting comments or words of wisdom that you'd like to leave us with?
No, I think, I think we're here to help. Any pediatricians that have concerns, questions about what they're seeing clinically, they're, absolutely free to refer the kids to us. They can even call, and ask questions too. Happy to answer phone, answer emails.
Well, wonderful. Well, again, I'm happy to be surrounded by a unicorn and this great service that y'all provide. So thank y'all so much for listening in. Hope you learned something. Again, cpfnashville@gmail.com. If you have any questions that we can forward for you, or any information that you need about referrals to Vanderbilt, we're happy to assist. So until next time, everybody, take care.
Thank you for joining Cumberland Conversations. We're proud to support the people who care for Tennessee's children. Don't forget to subscribe so you never miss an episode, and stay connected with CPF for more tools, trainings, and community updates. Until next time, take care.